Hi, everyone. Good evening. Thanks for tuning in to our webinar on erectile dysfunction. My name is Vinson Wang. I'm from the New York area. Went to medical school at Johns Hopkins in Baltimore, then performed my urologic residency training at New York Presbyterian Hospital, Columbia. I had a interest in sexual medicine. I really enjoyed the intimate aspects of sexual medicine and fertility, and so performed an extra year of specialized training in sexual medicine and andrology at Rush University in Chicago. So I deal quite a bit with erectile dysfunction, Peyronie's disease, low testosterone, and infertility. So what is erectile dysfunction? Erectile dysfunction is essentially the ongoing inability to achieve or maintain an erection firm enough to have sexual intercourse and to complete sexual intercourse to orgasm. And this definition is subjective. Every patient's expectations are different. And so it's our job as your urologists to tailor the workup and treatment of erectile dysfunction to each individual patient. So just some general statistics on erectile dysfunction. I like to say about half of guys over the age of 40 have some degree of erectile dysfunction. So it's extremely common. However, a lot of guys are embarrassed to bring this up to their doctors, to their urologist even. And I just wanted to point out that it's very common and there's nothing to be embarrassed about. So how does an erection work? I think of the penis as essentially three chambers. So there's the urethra on the underside of the penis that brings urine from your bladder out to the penis. And then there's really essentially two long erectile chambers that fill up with blood and in response to sexual stimulation to arousal, that causes dilation of the cavernous arteries that brings increased blood flow to the erectile chambers, which then causes expansion of the erectile tissues. That expansion causes compression of the outflow of blood from the penis. And so really, an erection is a matter of kind of blood in versus blood out. So if you have venous leak, if you have more blood flowing out than blood going in, then you're not going to get a good, stable erection. So there are many different causes of erectile dysfunction. It's also a complicated process, but about 70% of erectile dysfunction is caused by underlying comorbidities. So high blood pressure, high cholesterol, diabetes, smoking. These can all contribute to erectile dysfunction. Other causes include medications to treat these underlying comorbidities, like high blood pressure medications, medications for depression. However, these medications are important to treat your other health concerns. And so we typically don't recommend stopping any of these medications for the erectile dysfunction. And we can certainly treat the erectile dysfunction with medications and other options rather than having you, kind of stop your medications that are important for your other medical conditions. Other causes of erectile dysfunction include pelvic surgery or radiation therapy for men with prostate cancer. Low testosterone is another big contributing factor to erectile dysfunction. And so certainly one of the first steps to improving the quality of erections is behavioral modification. So modifying your diet, exercising, losing weight, as well as quitting smoking if you're a tobacco user. These can all improve the quality of your erections. A lot of other causes a lot of other urologic issues can be associated with erectile dysfunction. So low testosterone, Peyronie's disease, as well as not prostate cancer itself, but the treatment of prostate cancer, such as a surgical removal of the prostate, as well as radiation therapy. These can all impact erection quality. And so I'll touch on each of these a little bit further in the next few slides. So low testosterone is a important contributor towards erectile dysfunction. The incidence of testosterone deficiency increases as men age. Common signs and symptoms of low testosterone include low energy levels, fatigue, low sex drive, depression, as well as erectile dysfunction. So if you experience any of these symptoms along with the erectile dysfunction, it's important that you mention that to your doctor and to your urologist, and so they can do the proper testing for low testosterone in a setting of erectile dysfunction. So treatments for low testosterone, there are many different treatments. Oral therapies include clomiphene citrate or Clomid. That can actually, that's oral medication that can actually boost your body's own production of testosterone. And the other benefit is that it has less long-term dependency issues as opposed to exogenous testosterone replacement, which are the other options. So you have the testosterone gels or solutions that you can kind of rub on your arms. Or there are oral exogenous testosterone as well, like Gentenzo or Tilando, nasal sprays like Natesto, and then injection, like a lot of different types of testosterone injections, as well as pellets. And so if your urologist diagnoses you with low testosterone, then at the Urology Group, there's actually a dedicated team of specialists that can help manage your low testosterone. So they'll call you when your prescription's ready. They'll coordinate the blood work to ensure that your testosterone levels are appropriate, that your PSA as well as your red blood cell counts are not elevated, which are important, important to monitor while you're on testosterone. So another disease process associated with erectile dysfunction is Peyronie's disease. It's a condition that causes penile curvature, indentation deformity, loss of penile length, loss of penile sensation, as well as erectile dysfunction. The etiology of Peyronie's disease is not fully understood, but it's thought that there's a series of microtrauma to the penis in combination with genetic predisposition that causes aggressive scar formation and inappropriate scar remodeling that ultimately results in that plaque or scar tissue that you may feel in your penis. A lot of patients describe that as like lumps or bumps in their penis. It's more common in men over 50, and a lot of men don't like to mention this to their urologist due to stigma, embarrassment, and so I would encourage you to mention any curvature, any deformity of the penis to your urologist. Peyronie's disease treatment really depends on the phase of the Peyronie's disease. In the active or acute phase of Peyronie's, which is typically in the first 6 to 18 months following onset of the disease process, there can be oral therapies. However, oral therapies like vitamin E, colchicine, Potaba, these are there's poor evidence that it really does anything for Peyronie's disease. Some of the newer literature on oral pentoxifylline has shown some improvement and stabilization of Peyronie's disease with oral therapy. There's also penile traction, like the Restorex traction device, or PeneMaster Pro traction devices that can help with curvature as well as indentation deformity. Then there's Xiaflex, which is an injection of medication directly into the scar tissue. It's essentially an enzyme that breaks down collagen of that scar tissue, and that can help with curvature or correction of curvature from Peyronie's disease. And then when you get into the stable phase of Peyronie's disease, then there's options such as penile plication, trying to cut that scar out, so plaque excision and grafting, as well as more relevant to this talk, in patients with Peyronie's disease and erectile dysfunction, then a penile implant would potentially be your best option, because it does correct both the curvature as well as rigidity concerns with erectile dysfunction from Peyronie's disease. And your urologist can perform modeling maneuvers as well as incision, grafting, penile straightening maneuvers on top of that implant. So as I mentioned previously, the treatment for prostate cancer, such as radiation, surgical removal of the prostate, that can all lead to erectile dysfunction in the long run, because there are a lot of nerves that are responsible for erections that travel near the prostate. So treatment of prostate cancer can result in damage to those nerves and ultimately erectile dysfunction. So most types, if not all types of erectile dysfunction can be treated. So there are a lot of different treatment modalities for erectile dysfunction: oral medications, vacuum devices, shockwave therapy, injections of stronger medications directly into the penis, as well as penile implants. So for treatment of erectile dysfunction, there are many types of oral medications, essentially all PDE5 inhibitors that increase blood flow into the penis. It does require sexual stimulation. So if you take Viagra or Cialis, and you're not sexually stimulated, if you're watching like a baseball game or a football game, you're not going to get a spontaneous erection. And it is very effective in up to 80% of men. It's less effective in patients with more severe causes of erectile dysfunction, like patients who have had a prostatectomy or in cases of severe diabetes. It's rarely covered by insurance for the amount of medication that most patients need. However, over the years, as generic versions of Cialis and Viagra have come out, that cost has come down significantly. It used to be hundreds of dollars per pill even, and now it's only come down to a couple dollars per tab. The side effects of these medications include headaches, facial flushing, nasal congestion, visual changes, as well as potentially GI upset and back pain or muscle pain. The side effect profile for each of these oral options varies a little bit based on cross-reactivity to the different PD receptors. It's important to note that with all these oral medications, that you cannot take it if you're taking nitrites for chest pain. That's a contraindication. And so if you are taking nitrates, then you make sure you mention that to your doctor so that we can consider other options. So in terms of how to take Viagra and Cialis, Viagra, typically you need to take it about an hour before sexual activity. It has to be taken on an empty stomach because food can affect the absorption of the Viagra into the system. The half-life of Viagra or sildenafil is about 4 hours. So generally, it's ideal to be sexually active in that kind of 1 to 4 hour time range. For those reasons, I typically prefer Cialis or tadalafil because, just from a spontaneity standpoint, it's hard to time the Viagra to exactly when you want to be sexually active. A lot of patients don't want to worry about taking it on an empty stomach, trying to time sexual activity to when they're taking that medication. And a lot of patients just don't know when they're going to be sexually active. And so the benefits of tadalafil is that it's a lot longer acting. The half-life is about 17 and a half hours. So half of it will still be in your system at 18 hours following when you take it. The peak concentration of the tadalafil in your bloodstream is about 2 hours. So I encourage patients to take it at least 2 hours before sexual activity. And it's more forgiving of a medication. You don't have to worry about taking it with or without food. It's not the absorption of tadalafil is not impacted by the food in your GI tract, and because it's in your system a lot longer, you can take it 3-4 hours before sexual activity, and potentially even longer, and it'll still be effective. There are a couple different ways you could take it. There's a daily regimen, so taking the low dose 5 milligram of the tadalafil on a daily basis, and you can always take additional boosters of extra pills of the tadalafil if you truly know you're going to be sexually active, like on a weekend. So I think it's a great medication that is also titratable by the patient. And it also has benefits from a BPH standpoint. So a lot of our urologic patients have BPH, and have difficulties with urination, and so tadalafil taken on a daily basis can also improve your lower urinary tract symptoms. And so a lot of guys like to take the daily Cialis because of its impact both on the erectile side as well as their urinary side. Of course, the downside to taking the daily Cialis is that potentially cost. So if you're only sexually active, once a week or once every other week, or once a month, then potentially taking the higher dose, the 20 milligram dose as needed before when you're sexually active can be more cost effective. But I think both medications are great, medications to try initially. On a population basis, both tadalafil and sildenafil work similarly. Some patients will notice one medication works better than the other. Some patients will notice better or more tolerable side effects with one or the other. So there's technically no right or wrong answer. You could try both, but I prefer Cialis for its longer term of effectiveness. So I do want to mention that the Urology Group has a on-site pharmacy, so it offers competitive pricing of both Cialis and Viagra when you check out after you see your urologist. So you can certainly try some of these medications out the day of the appointment, and so you don't have to go to your local pharmacy. And the pharmacy will also mail these prescriptions right to your home. So it is a convenience offered to our patients. There are options for vacuum devices. Studies have shown it's effective for up to 80% of men. I'm not a big fan of the vacuum devices. I think there's a lack of spontaneity. You essentially have to use this vacuum device to create a negative pressure, bring blood into the penis. Once you get an erection, then you apply this constriction band at the base of the penis. There can be rigidity concerns as well, especially at the area of the constriction band that can cause sometimes hinging effect or instability of erections. But certainly it is an option if none of the other options sound appealing to you, or that's just something you wanted to try out. However, I do want to encourage you to try to get these devices through your urologist rather than purchasing them online. I have heard of patients kind of buying them like a non-medical grade vacuum device, and a lot of these devices don't have a pressure regulator and can cause bruising of the penis. Next, we have shockwave therapy for erectile dysfunction. Many patients here may have had kidney stones and potentially have had shockwave therapy for their kidney stones. And it's a similar technology, although in much lower doses of energy. It can be done in the office. Generally, 6 quick 15-minute treatments done in the office. It has essentially no downsides. There's no pain from the procedure itself, and I consider it a restorative option. So potentially, the way it works is that essentially a shockwave is applied to the penis and can cause essentially microtrauma to the penis, resulting in new blood vessel growth and increased blood flow to the penis. And it's been shown in randomized controlled trials to offer a improvement of erection quality in select patients with mild to moderate erectile dysfunction. So, I like to think of it as, a patient on low dose Cialis or Viagra. Shockwave therapy might get you off of oral medications, or in someone on maximal dose Viagra or Cialis, potentially with a erection just enough to have penetrative sex, but they kind of want something that works a little bit better. I think shockwave can potentially improve that rigidity. So certainly, I think not for everyone, and there's also no guarantee that the shockwave will improve your erections, but it is safe, and ultimately the main downside is potentially your time and the cost, roughly $2,000 for those 6 treatments of medication. So why the Urology Group? There's a lot of other groups in Cincinnati that offer this shockwave therapy, but it's essentially the first group of urologists in Cincinnati offering shockwave for erectile dysfunction. The benefits of considering shockwave with the Urology Group is that there is a team of urologists specialized in erectile dysfunction, as well as a dedicated team of medical personnel to apply the shockwave treatments, versus some of the other facilities that may offer the shockwave without truly understanding your medical history, if you'd be a good candidate for the shockwave therapy to begin with, and then they typically don't have the ability to offer you the other types of treatments like injections or the implant. So if you're interested in learning more about the shockwave therapy, you can certainly scan this QR code and then get set up with a free 15-minute online consultation to see if you'd be a good candidate for the shockwave, or you can also talk to your urologist. So the next treatment I'd like to talk about is injection therapy. So this is essentially injecting a stronger version of Cialis or Viagra directly into the penis. There's Trimix or Biomix. It's essentially a combination of piperine, phentolamine, and a prostadil. So these medications actually directly dilate the blood flow, the blood vessels to the penis, increasing your blood flow. So it does not depend on sexual arousal to work. However, it does involve a needle to inject the medication. So here's a diagram of essentially how you would inject a medication into the penis. The first few times that you do this, we would do it in the office. We would show you how to inject the medication into the penis. And then once you're more comfortable, then you'd be able to perform at home by yourself, or you could have your partner help with the injections. The medication typically takes about 5 to 20 minutes to work and can last for anywhere between half hour to an hour even. The greatest risk to these injections is potentially a prolonged erection lasting for more than 4 hours, which we call priapism. Because it does not depend on sexual arousal and it's a more potent medication injected directly into the penis, that is a much greater risk than oral medications for erectile dysfunction. It can be a little bit cumbersome because you do need to refrigerate the medication. It does have limited shelf life, and in coverage with insurances, can be problematic as well. And depending on how much medication you use, it can potentially cost you, $100, $200 every few months. Finally, I'd like to talk about penile implants. There's over a 95% patient and partner satisfaction rate with these penile implants. So essentially how it works is there's two cylindrical balloons that go into the shaft of the penis within that erectile chamber that I described previously. So the only thing it does is replace your mechanical ability to obtain an erection. So rather than blood being trapped in the erectile chambers, now you have this essentially balloon filled with salt water that provides that rigidity. So it does not affect your ability to urinate. It does not affect penile sensation, your ability to orgasm. So it's an excellent option for a lot of patients. And then following that schematic, there's a pump next to your testicles and your scrotum that allows the patient to control the implant. And there's a reservoir of fluid that's placed next to your bladder that gives the system fluid. So it's a closed system. Everything is internal. There's no kind of maintenance required with the prosthesis. In the flaccid state, it has excellent cosmesis. Essentially, you could be on a beach and no one would know you had an implant. And once you're ready for sexual activity, essentially all you do is pump that pump in your scrotum that transfers fluid from that reservoir through the pump into the cylinders. Then you'd have a nice rigid erection. You'd be able to perform for as long as you wanted to. And then once you're sexually satisfied, there's a little button on the top of the pump that allows you to essentially release a valve that allows fluid to go from the cylinders back into the reservoir. So it has excellent patient and partner satisfaction rates. A lot of my patients love the penile prosthesis. It's a short surgery, about an hour and a half. You'd be able to go home the same day. There's about a 1% chance of infection related to the surgery, and generally you're kind of out of service in terms sexually for a month. There's a week or two of kind of scrotal swelling, penile swelling, pain involved, but that does get better generally within that first month or so. It has excellent mechanical reliability. So at 10 years, about 80% of implants are functional. It's designed to last your entire life, but in younger patients, we do occasionally need to replace these implants. And then there's also an option of a malleable implant for patients with manual dexterity issues. So if you have trouble operating that pump, then your urologist may offer or may suggest that the malleable implant is a better option for you. Generally, the malleable implant is essentially two malleable rods that we place into the shaft of the penis, so it has no fluid in the system and no pump in the scrotum, no reservoir in the belly. And essentially, when you're ready for sexual activities, you can kind of move the penis into the position that you want it to be in. There's not as great rigidity as the inflatable penile prosthesis, but it does allow for a sufficient sexual penetration. So it is an option for patients with who wouldn't be good candidates for the inflatable penile prosthesis. So in summary, there are a variety of treatment options for erectile dysfunction. Don't get frustrated. Talk to your urologist to get the appropriate treatment for you. Erectile dysfunction is not, kind of the same for every patient. We have to kind of tailor a treatment for, based on your medical conditions and your sexual preferences, and then we can offer you the best option for you.